DPT. I always kind of like to give a little background and introduce how we know each other. And I don't know exactly what year was that when you interned pro?
I was just thinking that before we started. It's been, I graduated 4 years ago. So probably 2 years before that. It's been about 5, 6 years since I first, I guess, met you.
So that would have been right around COVID then, like right
Yeah, it
before I
was
got the job.
right after COVID. It was right
Yeah.
after COVID,
Yeah. So
2021-ish.
before was I at Fairmont yet? Or was I still just doing the internship at Pro?
I think you had just got at Fairmont,
Just
or
got at
maybe
Fairmont. Yeah, because
yeah,
you were there
yeah.
over the summer, right?
Mm-hmm.
So it was
Like
probably after my
intern, and then kind of turned into like a working position kind of
yeah,
after. Yeah.
yeah. So we've obviously know each other because of Pro Performance in Morgantown, and then your now husband, I guess boyfriend, fiance at the time, was worked with me last spring at Fairmont, Duncan, which I'll get him on here at some point. He's killing it at the high school strength coach level. Um, but yeah, it's good to catch up, and it's one of those things where I think my biggest thing for, other than just that I think you're a great PT, it's just my biggest thing is like you also, from my perspective, your perspective on strength on physical therapy is very much blended and united from a kind of a strength and conditioning approach. So I'm kind of excited to dig into that because I think we have a lot of like things in common with our thought process on that. Um,
Sure.
but yeah, just appreciate you being on here and looking forward to catching up. Um,
Yeah.
and you said this is your first podcast also,
Yeah.
so we'll
Yeah.
see.
It is.
You're gonna be fine. I just did another one with Tyler Carroll, right?
Yeah.
He was a GA for guy. I just had him on yesterday,
Yeah. I
so
just
he
saw him
was
again at Summer Strong, I guess
yeah.
in
So
May.
he was saying the same thing. He was like, "It's my first podcast. I'm nervous." I'm like, "Man, you're gonna be fine." And then honestly, he had I feel like he had one of the best podcasts I've ever done. Like he did a great job. So I think you guys just it's like we're at Summer Strong. That's what we're at Summer Strong. We're eating lunch, just talking about training, talking about PT, talking about training. So what is your current title? And then in your role and responsibilities, and then we'll kind of like work backwards from there.
Sure. So currently, my title is technically a sports physical therapist. I'm employed through a healthcare system called Prisma Health here in Columbia, South Carolina. So that's my employer, but I'm contracted over to South Carolina Athletics, primarily working with USC football. So I'm housed out of there every day. It was a little bit of blend of kind of a clinic or gym space that we had in one of our outpatient facilities, but throughout the year that I've been here now, it's kind of bleeded into more of I'm solely operating out of the training room, which has been really cool.
Yeah, is that something that's unique at the Division 1 level to where instead of having like PTs like on staff, they're like outsourcing that and like doing it
Yeah.
as contract work?
Yeah, no, that's a good question. That's kind of the topic of conversation for I think a lot of sports PTs wanting to get into this space of what is the dynamic. And every institution is a little bit different. I think of one, their philosophy and their belief in physical therapy versus maybe an athletic training profession. Like what does each have to offer? But honestly, one of the biggest ones is paying them. So a lot of institutions, they potentially don't want to pay them as much as what we're worth. And so either one, they'll outsource them to where maybe a PT from an outpatient facility or a hospital system will come in once or twice a week, which is what I had when I was at Liberty University. We had a PT contracted twice a week. So it's typically, I don't say 9 times out of 10, less than that now. It's becoming more common to have a full-time PT on staff with an institution. But again, depends on budget. It depends on philosophy, who the, director of sports medicine is, and if they value or want a full-time PT on staff. Some need to be dual credentialed, where they're PT, AT. Some, I think it's diving a little bit more and shifting a little bit more into PT, CSCS, or now like an SCS, which is your sports certified specialty within the PT profession. So that's kind of you're either employed through the institution, hired on staff, or you're maybe hired through a healthcare system and they'll contract you in either kind of part-time or in my case, luckily I'm more of a full-time over there.
Yeah, and we actually our head athletic trainer, he has a guy that we work with locally that he'll bring him in and do some stuff with some of our athletes. I know specifically I remember him working with two of our pitchers last year that had Tommy John.
Yeah.
So that's just something that's kind of allowing him to kind of focus in and hone in on those guys. Um,
Yeah.
are you have your CSCS?
Yeah, so I got my CSCS when I was an undergrad. It was actually had to take it in order to graduate. So I joke with people, if I had to take it now, I'd have to go back and read that book a few more times. But so I took it right when I graduated undergrad, and that's honestly kind of what got me into strength and conditioning was, I'm an exercise science major. I'm pre-professional, wanting to go the PT route. I'm required to take this, exam. I enjoy lifting weights. I enjoy the weight room. Let me take this exam. And once I took it, I was like, well, I have it. I don't really know what I'm going to do with it. I've been an athlete in a weight room, but I don't really know the other side of it. And that's kind of what got me into my whole strength and conditioning journey. Was after I got that CSCS.
Yeah. And what kind of, I want to touch base on all your different stops along the way, but what was it initially that made you want to be a physical therapist?
Yeah, so I had my first ACL surgery when I was in high school. So I committed. I played soccer growing up. I committed to play soccer at Liberty University my junior year, and about 3 months later tore my ACL. So that's kind of my first exposure to PT. And in southern West Virginia, the middle of nowhere, there's not very many PT clinics or opportunities. You only get two options. So it was definitely more of a traditional PT clinic, to where, I didn't run until 6 months. I didn't touch a soccer ball again until 9 months. And when I stepped foot on campus again, to play at Division I level, I had barely touched a soccer ball. So I was very behind in my rehab there. But I spent my whole freshman year kind of recovering, played a little bit towards into the end of the season, my spring, played over the summer, and then first came back my sophomore year, I tore my other one. So I was kind of out again for an additional year, basically. But I think for that first experience and definitely the second, I started to kind of ask the questions of like, why, right? Like why did it happen in the first place? And then why did I just spend a year of my life recovering and now I got to go through it all again for another year? So really just question like, why does the body function the way it does? But more specifically, like, what does it take to get somebody back safely? And what did I do before? And now what am I going to do this time? And that kind of just started to develop more and more of my passion for understanding the body and how it works. And then, so I recovered my sophomore year, and then like a week before preseason, my junior year, within like 2 weeks, I went for a cut and my other one gave out again. So I kind of did this in and out my junior year of,
Mm.
my knee was loose, it swelled and everything, got the MRI, but it didn't really show it was torn. I tried to do rehab, got back in, it would give out again. So it just wasn't functioning. And so I spent my spring of my junior year, after like my third MRI, like I can't do it anymore. So I had a revision on my first one. So I've had three total. And at that point, I was pretty set on PT. I kind of had a career path ready for me. And I was like, I'm not going to try to play an additional year and have a fourth. So at that point, I medically retired and I kind of helped out my senior year with the team. Actually, we just got a catapult at that point. So it was kind of cool for me to dive into that for the first time. Yeah, basically just serve the team. But that led me down into not only PT, but specifically sports, and then specifically strength and conditioning. Like what did I do in the weight room? What should I have done? What did I do in PT? What should I maybe have done? And this has kind of been my journey over the past, gosh, I mean, I'm just now finally getting to what I want to do. It took me, 3 years after graduating PT school to get more training and more experience, to be able to have the position I have right now, to ensure these athletes not only get the care that they need, but ensure that the phases and the transitions are appropriate to make sure that they're safe returning, to where hopefully they never have, 2, 3 plus ACLs. So yeah.
Yeah. I mean, that sucks. I knew that you had torn your ACL. I don't know if I knew that you had three of them. I don't know if I knew that aspect. And remind me, you're from like we're near Concord, like near Athens,
Yeah.
West Virginia.
I
Yeah.
could throw a rock to Concord's campus. Yeah, so
Yeah.
my dad was a soccer coach there for, gosh, 20 plus years, and recently retired about 4 or 5 years ago.
Okay. Um, so, we'll kind of continue to get through your coaching or your professional career, not your coaching, professional career, but we're on the topic of ACLs, and that was something I was going to talk to you about anyways.
Yeah.
Let's start on like the preventative side. Obviously, I know there was a big study. I saw it. I think it was it was in one of the Nordic countries, Scandinavian countries, looking at like adolescent females. I can't remember the exact age. I want to say, I don't know what they considered adolescents, like 12 or post puberty or something. They had some kind of line drawn and saying up to like 18 years old or whatever. And the number one predictor when they ran all this longitudinal study, the number one predictor was, or predictor of not getting a knee injury. And I think they looked at not just ACLs, but any knee injury that sidelined the athletes for an extended period of time. And I'd have to go back and reread the entire study. The number one predictor was the girls being able to squat 1.5 times their body weight. That was the number one predictor, or whatever predictor of it not occurring. And which again, like, I think that seems like a high number for like a high school freshman, sophomore, but like, as I think of like our college athletes, and I maybe even overshooting, it might've been like 1.3 or 1.25 or something. I can't remember exact number, but I know that number that stood out to me because when I thought about the number, I'm like, okay, that might be a little high for a freshman or a sophomore in high school, but if they're training, like, that's a pretty reason. I mean, you figure like, average, I don't know, one of our soccer girls probably average rate around 130, 140, like that's a 200-pound squat. Like that's pretty reasonable, right? You have to work towards it. It's pretty reasonable. And that's the high threshold. Looking back at, and again, I don't want you to like blame anybody or point the finger. I mean, unless you feel like you want to or whatever, but like, what do you think, like, you going back, like if you were to have a daughter, we'll say daughter in this situation because of being women's sport, women's soccer, if you were to have a daughter, what would be like the number one things preventatively that you feel like need to be addressed? And again, this is assuming that injury prevention is a real thing, which I don't think it actually always is, but to put that athlete in the best position possible, what you at this point in your career kind of generally recommend?
Yeah, no, I joke with Duncan a little bit. I've had 3. He's technically had 1 too. I don't know if you knew that, but so
I forget
basically,
what his was.
if we have a girl, they're gonna play chess. I don't think they're gonna be playing any form of.
Remind me what Duncan did. Duncan did something crazy, right?
It was stupid. It was a lift. He was I think it was
like a push press or a jerk or something, wasn't it?
Yeah, it was like a push press. It was one of like strongman competitions, and he like got it up, and as he dipped, his knee just like gave out. So yeah, all of mine were non-contact. His were non-contact. So, yeah, we joke like my girl plays soccer, then she might be doomed. But no, it's a good question. I think I argue what term you want to use. If it's prevention, I used to say more reduction because it's really tough. You can read one study, but is it controlling for this? And you read another study, is it controlling for that? It's so, I don't know, use the word multifactorial because it really is. And is it strength? Yes. For me, like, I never touched a weight until I got to college. Like, I would walk over to Concord and they had a community gym, and I would get on the ab machine and I would do a couple like things. I'd never touched a barbell until I got to college, which is kind of crazy of where I'm at now. And I, competed in weightlifting for a couple years there. Like, I love it. And I think looking back, like, what would have helped me is to have a set program, a set foundational strength level going in. But then, I would say, I would argue is, I came back from that first one and I spent my entire freshman year, like, I mean, they say the freshman 15, like, I gained some muscle. I feel like I got strong over that first year, whether it was all neural, who knows. But, like, I got really strong. I lifted a lot that whole spring season. And then first came back, I tore my other ones. It's like, well, is it a strength thing? Because I just spent a whole year and I was a lot stronger than I was before. I think that then goes into the next question or proposal of, other things that were going on. But yeah, I would say the number one thing for me was definitely probably just strength. And I think when we look at your youth athlete, especially the high school kids, because the high school is probably where you're going to see the biggest or increased maybe risk or the highest case scenarios of kids tearing their ACL, especially females, because a lot of them aren't on a solid strength program. Like, I didn't have a strength coach. I didn't lift weights when I was in high school because we didn't even have them in Southern West Virginia. Obviously, that's changed and evolved a lot over the past 10 years. But I look at like the high school that Duncan coaches at now. He's got all these females in there. I'm like, I never had that when I was in high school. So I think that's a start, is seeing the value of being on a solid strength and conditioning program and preparing these athletes for the demands we put them through. And I think that's the biggest thing I see is we're asking these kids to play all these sports and to go play club ball, and then, well, I got to go back and train at the high school, but I've actually got this tournament this weekend, and then my season starts next week. And it's like, when do they actually rest? And the load that they're putting on their body over and over and over again, to not allow the appropriate rest, and then you potentially are putting load on a body that isn't properly trained for it. So I think that's one piece. If you want to like put it into one bubble, would be the strength and capacity that these kids are trying to work at but aren't able to, I think would be one category that you could touch on for ACL reduction, within a controllable factor.
Yeah. Well, it's, you say that, and like, I literally, as you're saying it, I just thought about the fact that, like, professional sports have gotten very consumed with load management, obviously because those athletes are quote unquote worth a lot of money. At the collegiate level, people are worried about load management, which I'm in favor of all that stuff. I think it all makes sense. But little Johnny and little, Janie that are playing high school sports, like, no one is thinking about load management. Like, other than
No.
maybe a high school baseball coach that's worried about how many pitches a pitcher's thrown.
Yeah.
Like, a basketball player at a high school level is not worried about how many times that kid runs up and down the court. A high school soccer or football coach is not worried about. So I think it's definitely that. I think it's, and I think it's also just a changing body, like a developing body is a factor.
Right.
And that's something too that, we talk about this. I mentioned this with like our A&T coach about some of the injuries we've had there. And, you're going from especially the gymnasts, like we're bringing in these gymnasts that have been doing gymnastics since they were 5 years old or around that age. And, they've now gone through puberty, and now they're not like a 14, 15, 16-year-old girl anymore. Like, they're like a young woman, and like there's a difference there. Like, and you're not, their joints are not the same. Like, their tissues are not, their tendons, their ligaments are not the same. And again, that's not a good excuse. That's just a reality. Like, that's what it is. Like, we have to deal in things that we know are realities, and try to make some assumptions based off that. But I mean, did you play other sports, or were you only playing soccer?
By the time I got to high school, I did in middle school, I attempted to play basketball. I ran track. By the time I got to high school, though, it was focused on soccer. I ran track in the off season. But I was pretty much a one sport athlete by the time I got to high school.
And obviously, like, I'm a big believer in, playing as many sports as you possibly can. And mainly because of just when you were in school, it wasn't as bad. Like, when I was in school, like, nobody really played travel ball. Like, when I was in like middle school, high school, like, travel ball wasn't really a thing. Like, if you were good enough to be on your all-star team at the end of baseball season, you'd go and play in like one or two all-star tournaments, an hour or two away, and that was it. So I think it's also just like, I don't even necessarily think kids need to rest, because I think most kids are probably like inherently too lazy as it is. I think it's just like time off from that single sport. They just need a different stimulus. Like, they need to play soccer in the fall. They need to, do something different in the winter. They need to run track in the spring. They need to, play whatever, like pick up basketball or something in the, like, just do something different. Like, just get some different movement patterns. Because especially if you're not strength training, then you're only getting those repetitive movement patterns.
Right.
So kind of on like the flip side of that now, and this is something that's really, like, I have a really hard time wrapping my brain around sometimes, because we've had athletes at Fairmont that have torn their ACL. I mean, we had and I use him as an example all the time. I mean, he was just a workhorse and just a stud, but we had a center on the basketball team a couple years back. He was one of our Iron Falcon winners. He had the unhappy triad. So this was in February, got surgery in March. He came back and played in the first games of this. He started every game of that next year in November. So it was like 7 to 8 months post surgery. He came back and played and started every game, and then came back the next year and still started every game. So it's something where, he was obviously a physical specimen to begin with, to an extent. And then we've had, unfortunately, some female athletes that literally have had one and then tear their second one. And so the point I'm getting at is, aside from just maybe, because again, I don't doubt like your work ethic. I don't doubt that you were like not busting your butt to get back. And again, we've had athletes that have done that and still don't get back to where they were. What is maybe some underlying things that's going on to where, let's treat like a twin study. Like, you have two twins, identical twins. They both tear their ACL, both have the exact same surgery, whatever. They have a patellar graft, hamstring graft, whatever, right? The exact same surgery done by the exact same surgeon, which I also wonder sometimes, is surgery ever the exact same? They both have the same rehab program. Like, what factors go into that return to play? I know we've talked about, you and I have had the conversation of like an ACL as being like that's a neurological injury. Like, your brain has to relearn. So kind of like give us that whole cascade in terms of like what can separate a successful return to play versus an unsuccessful return to play.
Yeah, and I think the biggest thing to keep in mind, and what, not to scare my patients or athletes, but honestly what I tell them or inform them at the very beginning, just for reality, like, this is factual. If you want to go look up a paper and I can give it to you, is unfortunately when you have that first ACL, your likelihood of a re-tear or of a contralateral or the other side tearing is very, very high, like 4 or 5 times as high. And that's just what the literature points to. And again, it goes back to before, is like, okay, well, Was it a true return to sport? Did you hit all the measurables you need to hit? Is it a, we didn't touch on it, like a hormonal thing? You got some weird hormones that are causing laxity and stuff. Is it a, equipment? Is it your shoes? Is it contact, non-contact, right? If it's contact, unfortunately, there's an unfortunate situation for you. Or was it like non-contact, and like maybe you have something structurally. So not to get too deep into the anatomy, but sometimes people are just predisposed based off of, we call it like the tibial slope. So you got your femur and you got your tibia here, like the tibial plateau, if it's super flat, versus sometimes it's at an angle. And if it's at a certain angle, then that can put extra stress on the ACL. We did a lot of that back when I was in Houston in my residency. We had a lot of slope reducing osteotomies with an ACL. So if it's a revision, meaning like you had your surgery, you went out, you retore it. Well, why did you re-tear it? Outside of just maybe your strength, maybe the outcomes that you did or didn't hit, but like structurally, what's going on with the stress of the ACL, and a lot sometimes it's the plateau. So they'll literally like shave a portion of the tibia and bring it down so the plateau is more flat and it doesn't put excess stress. So that's getting a little bit more technical, but like, so there's so many things that go into it. The controllable factors, again, from like a physical therapy standpoint of tore ACL, we are now at the end stage, and I'm deeming you appropriate to get back into full play. There's a list of battery of tests that I look through and I perform. It's kind of based on the sport and based on the position, right? An O lineman, I'm going to treat a lot differently in their ACL compared to a wide receiver, compared to like a basketball player. The demands of the sport, their body composition, I'm going to test them differently. But in general, I have basic things that everybody kind of hits. So I don't know if you want to go into that now, but that's kind of a portion of things that I look at. But in terms of the twins, right? Like say they both do all those and they both all pass, it's tough. Is it, did you just step weird? Is it a neurological thing? Like there's a lot of ACL in the brain research coming out. A big one that's spearheading all that, two of them is Dustin Grooms and Meredith Chaput. They're like the two like top people of doing all kinds of research on brain mapping and doing a lot more of like proprioceptive work. Like we all know to stand on a AirX foam pad and to do nudges and perturbation work, but like going on a deeper level of what's actually going on in the brain when somebody tears their ACL, that we technically can't necessarily test for in a standard clinic, but maybe we can test for like an actual research lab. So they're researching that a lot more. That's an area that I'm just continuing to explore of what ways can I incorporate that kind of training into my rehab, especially at the end stage. But I don't know if that kind of answers the question of all the different things that kind of go into it or to consider.
Yeah, I mean, I think the biggest thing is obviously, and an athlete's work ethic is definitely a factor. Like I said, we're going back to Seth. Like Seth would go to our athletic trainer like when he needed to be there 5 days a week, but once he was able to transition with me, he would be with him 3 days a week. He'd come with me 2 to 3 plus days a week throughout the summer. And then he would go to like the gym in town and just do bodybuilding stuff. And I think that was a big factor too, because there is an aspect where, and this is going to sound like an excuse. It's just reality, unfortunately, is like when you have the time constraints that we have, especially at Fairmont State, where like I just don't have the equipment or the time to always get with an athlete and do single leg knee extensions until their quads are ready to fall off. Like unfortunately we just don't have that ability. Whereas like Seth would kind of go and do that stuff on his own. And then we've had athletes that haven't done all that extra work and also still end up being successful. So it's like it's one of those things where I just kind of get caught in the middle of like how much of it can you blame on their return to play? How much can you blame on like me not doing enough as a strength coach? How much can you blame it on the athlete not doing their part and eating and sleeping and taking care of their body versus some of it's just the surgery didn't go well. Like it's just one of the things, like you said, it's almost too many factors to really tie it all down. But I just wonder, like, I guess my thing is like just the guilty conscience of like, how do I make sure I'm doing enough, but also knowing that how do we even know what is enough? Because for one person it might be enough, for one person it's not enough.
Right. No, I think a big piece to sum it all up, and what I've learned, honestly, operating at several different levels now and seeing different caliber of athletes, it really is genetics and seeing those that return faster or those that, didn't have to put in as much work, but still came back and was very successful versus somebody that worked their ass off and, did everything you told them to, but then had setbacks and, you know, it's the way their body heals, it's the way their body recovers. That it's the same people that go eat McDonald's all the time, but will still like run, 21 and still make the game winning catch and then get 4 hours of sleep. Like sometimes it's just those freak genetics that, I'm currently seeing with a couple of rehabs that I have right now that, it's like holding their hand to do everything. But yet they look amazing, and it's like you love it for them, but you're also frustrated because you know how much maybe better they could be if they listen versus those that like they're literally waiting for you to give them more all the time and they'll do whatever you tell them, but they're still having issues a year out.
Yeah.
So it's tough. It's very tough.
Yeah. No, for sure. I mean, like, and again, this isn't like the bash surgeons or anything like that. Obviously, like
Yeah.
orthopedic surgeons are great, but I mean, is there a reality of like not every surgery? Like I say that out loud to other people, but like, is that like a reality that I'm kind of on to something where like every single surgery is probably, and this is whatever surgery, a labrum surgery, a rotator cuff tear surgery, like where every single surgery is not going to be exact, like the body is
Yeah.
just not going to accept it the exact same.
100%. Yeah. Surgical technique is huge. And I think it's something that obviously you never like, I want to go blame a physician for something. It's just like to
Right.
blame me for rehab or to blame the patient because there are a lot of different things that go into it. But I think that's something, you know, if you're not within the medical realm or even me, like learning as I was going through residency fellowship and being exposed to different physicians, is that surgical technique is huge and it can contribute a lot to the success of the graft, of how it was, when you drill tunnels. Traditionally, way back in the day, they used to drill ACLs straight up and down, very vertical. And that honestly was part of, I think, my first one, why I needed a revision. But like the tunnels, they were very vertical. And now it should be more of like, at an angle. Some made them very anterior versus some drill the holes a little bit posterior. So it's all on technique, right? You go to a physician because it's the only one you have in town when you live in the middle of nowhere, West Virginia. You don't have 15 surgeons to pick from.
Right.
And when you have that surgeon that does total knees for a living, but he gets 2 ACLs that come in for that year, like it's like reps, right? It's like doing a clean. If I did a clean every other day, I'd be really good. If I did a clean twice a year, I probably wouldn't be very good at cleans. So I don't know to compare it to that kind of, but like it really is surgical technique does matter. And old philosophies and newer philosophies, newer techniques that are done based off of research and seeing, well, hey, all these tunnels were drilled vertically, and look how many re-tears we've had. Therefore, let's change our surgical technique, and that's just medicine, right? That's how it always
Right.
evolves.
Yeah. Yeah.
And I'm just obviously ACL is kind of the easiest one to talk about. Obviously, there's other procedures. I think a big one that I learned in residency is honestly just tourniquet time, of how long you're under the scope or under the knife and how long your blood is cut off. So longer tourniquet time, meaning like more swelling, like the body, it's going to be harder for the tissue to recover and heal versus maybe a faster surgeon where you're not under anesthesia and under a tourniquet for as long. Um, so I think that's a big contribution too.
Mm.
But again, it's tough. You can't say that's the problem, or you can't
Right.
say
Right.
like
Right.
it was a PT the problem. But I think it's just considering all things. And as a PT, I see them every day. A physician will see them once a month, every 4 to 2 months, 3 months. When I see them every day, and then I see multiple people, you start making comparisons, and you saying, well, this guy did good. What did he have? Well, this guy didn't do good. What happened? And you're always trialing and changing different things to figure out like what truly works with that physician and that technique that's done.
Yeah. No, that definitely makes sense. And again, I mean, you answered the question. It's just unfortunately there's really not no right or wrong. And it's so many factors. That's the thing is that,
It's tough.
I didn't expect to like solve my like mental
Yeah.
dilemma, but it is what it is. It's something
And
that
I,
like it makes me feel better about that I also stress out about it because,
yeah,
you know, even somebody that's more of an expert about it than I am, like you are,
yeah,
like you also are still like you
yeah.
we don't
And
have
I
to
mean,
let you
that's
get,
why
the
when
answers.
you go to PubMed and you type in ACL like research or ACL rehab, there's thousands and thousands just within the past 10 years. But you type in like labrum surgery. Doesn't happen as frequently. So then you pose the questions like, well, why the hell do we have all this research and we still have so many like
Yeah.
ACL tears?
Yeah.
So
Well,
it
and
just
that's
keeps perpetuating the question of like, well, is it that? Is it that? Well, let's control for this and do this research. But um, there's so many factors
yeah,
to
when
stop.
it even kind of goes back to what we said at the beginning of like, obviously we know that strength and conditioning improves performance, but I think you can make the argument of like, okay, we've been to, you look at like, especially like maybe not at the Division II at the high school level, but you look at like in professional sports, like professional sports have continued to drive up performance over the last 15, 20 years, but injury rates really haven't changed.
Yeah.
So it's one of those things where, and I've said this multiple times too, it's like as performance goes up, unfortunately, you're turning a little Honda Civic into a Lamborghini. Like if that Lamborghini blows a tire, it's going to be a lot more catastrophic than if a Honda Civic blows a tire. So like it's just
Yeah.
unfortunately it's just part of the deal. And that's I hate that that's the reality, but again, that's also the reality that we all have to deal with.
Yeah,
I do want to get into like some of your testing battery stuff,
for
but
sure.
before we do that, like let's just like go back and kind of just run through your profession, your professional path. And then I want to kind of have a second question to that in terms of just kind of like your overarching kind of like just principles and PT approach. So what has
Yeah.
been your path? So obviously, you mentioned Liberty for undergrad, and then what was your next steps?
Yeah, so I left Liberty. So I graduated a little early, and my last semester before I started PT school was kind of my first strength and conditioning internship with Liberty Olympic Sports. So that's kind of what evolved. And honestly, if I would have known or had that earlier, I probably wouldn't have maybe even become a PT. I think that was my first exposure. Like, wow, like I love the weight room. Like, I want to be a strength coach. But in my head and my heart, I always knew I wanted to be a PT. Like, that's just where I needed to go. So then I started developing this passion or desire question of like, well, how do I blend the two? How can I go get this degree of PT with this new passion for strength and conditioning, and how can I merge them and mold them to eventually get back into the college setting where I can help these athletes get back. That was kind of my mission from Liberty into PT school. When I was at PT school, obviously I got involved with pro performance, tried to continue to develop my skills as a strength coach, spent a little time with West Virginia athletics and their Olympic sports shadowing. And then I applied for residency. So when you finish PT school, you can just go be a PT. But if you want to specialize and try to get in within a certain population, you can do a residency. So I applied and I stopped interviewing and I didn't get in. I was told no from a lot of people. So at that point, I was like, well, what do I suck at and what do I need to keep working on to get me to my end goal? So I moved to Maryland and I did an internship with Maryland football, which was my first football exposure and ultimately was a turning point in my career. Coach Ryan Davis was a big impact in my life and just exposing me to the sport and to the environment and how to be a 5'1", female with a pretty soft voice. How can I coach a floor? How can I lead a group? So he was a big pivotal part in my life, and for me to then understand like what else do I need to do, experience I need to get into football. So I stayed in Maryland, worked as a PT for a little bit, reapplied for sport residency programs and got in. Um, so in the midst of kind of figuring out I got in, finishing up my job there, I reached out to my old teammate at Clemson. She's Erica. She's a assistant Olympic sports strength and conditioning coach. Reached out to her and was like, "Hey, can I just come do an internship? This is my last summer really to be a free intern and just learn before I really need to start like earning money and like working in my profession." So I quit my job, packed up all my stuff, and lived on a futon for 2.5 months down at Clemson, and did an internship with them, which is ultimately where I met Duncan. So I don't regret any of it. But I spent 2 months there over summer, and then moved straight from there out to Texas. So I did my sport residency with Memorial Hermann. I was contracted to like a small D1 school there in a high school. Did that for about a year, 11 months. And then from there, I realized like, okay, I'm in sports. I know how to treat sports, but I don't want to work in a clinic. I want to work in the Division I setting. So when you finish that, you can then further specialize if you want. And that's where I did my Division I fellowship with West Virginia athletics. So every time I keep leaving the state, somehow I keep go back to it. But I went back for another year, and that's where I was at about 2 years ago now, working with West Virginia athletics. I rotated between football, basketball, and baseball, whatever team was in season, and basically overseeing post-ops, rehabs, game day experiences. And from there, I tried to figure out what the next move was, and it was South Carolina. So that's kind of what I do now.
No, that's awesome. And honestly, I don't know if I remember knowing about the Maryland position.
Yeah.
And I mean, honestly, that's, for lack of a better way of saying it, that's pretty ballsy to like know that you have your PT degree. And instead of just like, hey, I'm going to go work in a clinic and make whatever a PT's salary is, a very solid salary, and just be content with that. Like, you were like, you know what, I'm going to go and I'm going to do two unpaid internships essentially, and to get experience, to get your foot in the door, build your resume. And I didn't know that part. That's something that's really cool. It's really cool to hear you say that, because I gained more respect for you, I guess, is the nicest way to say that.
Home health on the weekends, that paid my bill.
Yeah,
that's
and again,
multiple people around the home pays my bill,
Yeah.
so I during the weekdays can do what I love doing. So
yeah, that's awesome. It's funny you say that too, because I originally wanted to do PT too before I didn't really know about strength conditioning being a profession either. When I was at WU, I went home one summer between my junior and senior year, and I worked at a inpatient nursing home. And I was there for like 2 months to get my hours, and I could not wait to be done. I was like, I do not know if I want to, like, I don't want to get stuck doing this. Like, I don't want to be doing this. Like, one of RPT one time would be getting this old grouchy man out of bed to use the toilet instead of just like shitting in his bed. Like, that was his PT. Like, his PT was like a successful day. Like, we checked that box off if we could get him to go use the toilet instead of like soiling his sheets. Like, I'd be like, oh
and you
my
know
God.
what's crazy, Adam, is that's what pays the most. Like,
I know.
if I want to go make some money, I'm going to go to a nursing home, or I'm going to go do skill, like we call it SNF.
Which honestly, like, I kind of get that, because it's like, it's the job that's really like the worst one. Like, so I understand why it's getting paid the most. You know what I mean? Like, I kind of do understand that. But it is kind of crazy. But that's when I was like, I need to think about maybe another route so that I can make sure I work with athletes. But you've done that route, which is awesome. So what is your, like, kind of all those steps along the way? What has been like I'm sure this has developed over the years, like your kind of philosophy as a PT, especially a sport PT, like what has kind of been like, maybe how it's evolved, but what is that philosophy, the standards, your principles, like your mission statement, like what do you present that as a PT?
Yeah. So what I like to kind of quote, and I don't know if it's just something that's kind of developed over the years or it's kind of ingrained in my head. Maybe I heard it from someone else, but the idea of like rehab for an athlete specifically, rehab is training and training is rehab. Like, it's a blend. Strength and conditioning is rehab, and rehab strength and conditioning. Pending what phase you're in, you might just be significantly modified to whatever pattern that you plan on hitting. Right. So if like you're going to squat in the weight room today and you're 2 weeks out, okay, well, you're probably not going to maybe squat on that one leg. You might do like, squat to a bench, or you might do a single leg squat. Like, we're still going to hit the pattern. It's just going to be modified. And so that's kind of my philosophy within athletics is, you might be removed temporarily, but how can we start to reintegrate some of these movement patterns, these basic patterns, in such a way to meet you where you're currently at. And as you get stronger, as you develop more motion, as your pain gets better, we're going to progress it to the point where instead of doing a single leg balance, you're going to march, and then you're going to skip, and then you're going to bound, and you're going to run. Like, it's just the progression of patterns. And I think that's what, as I look back and reflect of the blessing it was to be exposed to so many different strength coaches, is learning how they coach, how they cue, how they modify a pattern, like in the moment. And that's ultimately what it is, because at the end of the day, like when they leave me, they're going back to the weight room. So whatever I'm doing needs to parallel with what they're about to go back to, if not just work hand in hand. So that's been my philosophy. I guess I'm a little biased based off of my background in the weight room and just my passion for that space. But that's how I like to treat it. Now, again, it's every job I've been in, it's looked a little different of what that integration looks like, and optimally what I would love to see versus what realistically happened. But ultimately, a best case scenario is when you're working hand in hand with the strength coach from day one, and then slowly integrating, getting them more incorporated with the team. I think just what I've learned from a football standpoint is when you've got, 100, 120 guys and you only have 2 lifts, it's like, well, you do the math of how many guys are in there at the same time. You only have so many eyes. Like, I don't want an intern running my 3-week post-op ACL through the rehab or through their exercises. They need more eyes. They need more one-on-one. And I think that's sometimes the struggle is what is that integration? Who's working with them? Who has eyes? Um, I think something that I'm currently still trying to work out and what that flow looks like. But I think at the end of the day, that the athlete needs to get back with the team as fast as they can, but in a safe environment for them.
Yeah, no, I think that's perfect. And again, I think it's just one of those things where, and again, I don't know a ton of physical therapists, but like aside from maybe you and Dr. Nick Kyle, like I don't know anybody that like I mean Nick, you go to Nick Kyle's clinic, and I know you've
Oh
been
yeah.
on the move, right? Like you go
Oh
to his
yeah.
clinic, and it looks like a weight room. It looks like a college
Yeah.
weight room. Like it's not just a bunch of machines and a bunch of bands, and
Yeah.
and again, I understand that stuff makes sense for your average like adult ACL, your average grandma, with a rotator cuff or like sciatica or whatever. Like I get how that works, but I definitely think there probably needs to be a different perspective and a different approach when you're dealing with, especially like Division I football players. Like they're just different.
Right.
They're a different type of human being. Like they need different types of rehab, like just higher level stuff.
Yeah.
And yeah, it's something that I do think like we do a good job at that's something I try to take a lot of pride in. We do a good job of like if an athlete is injured, like we definitely try to work around as much as we can. Like we're going to work the other leg, we're going to work the upper body, especially if they're not completely clear to do anything on that leg yet. And once they're clear to do something on that leg or that injured appendage, like we're going to do what they can and kind of go through that
Right.
pain-free range of motion. And if it has to stay closed chain, we'll stay closed chain. Like it is what it is what it is. So I think I love to hear that because I'm with you on that. I think the number one thing for preventing injuries is strength and conditioning, and the number one thing for treating injuries is strength and conditioning. Like
Yeah.
again, I'm very biased, obviously, but
Yeah.
I just think it makes sense. You kind of so let's get into the actually I might wait for the testing battery thing. I want to go through that here in a second. You
Yeah.
mentioned like obviously us as strength coaches, physical therapists, athletic trainers. What kind of model? And I know you've been at a couple different D1 stops, so you can maybe even kind of combine your experiences and you don't have to like name drop places that did things well or did things bad. But what does like the ideal situation look like of that kind of what I'm going to call the high performance team, where you have your sports med, strength and conditioning, sports nutrition, and now obviously something that I think's probably obviously growing. I don't think it. I know it is growing as the sports psych. Which again, did you have a sports psychologist when you were at Liberty?
Um, no, not with the
Yeah.
team.
So like again, even just 10 years ago, whereas I'm sure now they probably have something. They
Oh,
probably
for
have a
sure.
contract with somebody or somebody's going
For
there.
sure.
So you have those four things. Plus, then you have like the regular coaches of that sport of that athlete. What does like that ideal kind of high performance team look like? Sports science. We'll throw sports science in there as well. Like, what is that? What do you think that like has looked like, should look like, and
Yeah.
how does that relationship kind of be developed and maintained? 'Cause again, everybody has their own lane, but everybody's lane to an extent like overlaps. Like you can't, like you said, you can't do PT without or rehab without strength and conditioning. You can't do strength and conditioning without nutrition. You can't do rehab without sports psych, right? And then you
Right.
can't do any of those things without having which that's why I kind of wanted to ask this first. You can't do any of that without having your sports science testing to see
Yeah.
if any of the shit that you're doing is actually working or not.
Right.
So what does that look like?
Yeah, no, good question. I think it looks different everywhere. When I was in residency versus fellowship versus now, like it's looked different everywhere. And I think a lot of that is based off of resources, right? So some programs are going to have, full-time sports psych that's literally in the facility. And then some have it where they cycle in, once a week, and that's your time to talk to them. Or nutrition, like they might be there full time versus they might pop in like on a game day or they're on call when needed. Um, so I think it depends on what's readily available to you. I think, you know, a perfect case scenario, I would take a guy for an example just to take you through a real life. So if somebody just has surgery, I think all parties within a high performance model, everybody you just mentioned, they need to be involved in some capacity. However, I feel like there has to be one main team player that not necessarily controls it, but guides the process, right? Like one main player, because if there's a lot of different people in the pot, then it gets confusing and communication is going to get lost. So what are we doing this day? Well, what did he do there? Well, what are we planning on doing? So one person has to guide and direct. And I feel like in a high elite setting, and it is a post-op, like a physical therapist can help guide that. Now, that doesn't mean they are the only player, like the athletic trainer that's working alongside of them. Maybe they take them 2 days of the week or 3 days of the week. or maybe while I'm in the ATR, like they're out on the field with them, or vice versa. Um, so I think starting that process of like, I'm in charge, this is the plan. However, this is what you're going to do. What do you think on it? What would you rather do? And then from a strength and conditioning standpoint, hey, like what plan do you have? I think that's the biggest recommendation I would have for strength coaches is like you probably are going to have a training block, hopefully written up, like a 2-week, 3-week, 4-week training block. Like, what is that block? Can I see it? Like, let's talk through it. And then, okay, what modifications do you want? Like, you're planning on doing, a trap bar deadlift. He can't do that. What would you rather do? Can we do this? Cool. I like it. Like, I don't need to tell you how to do your job. I know you know how to make modifications, but let's talk about like what modifications are necessary for their safety. And obviously, as that relationship builds, maybe that strength coach can start doing that without even fully needing a conversation when you do it, fairly regularly. But as you're building that relationship, like let's sit down and talk. If that's your 4-week training block and that's what guys are doing, well, these are the modifications that are needed. Can we stick to this block? Obviously, there day to day there might be changes that are needed. But this is the block. Can I have it? So that way, if they're going to see me first, let me prep them for you. So that way I'm not doing 4 sets of 8 squats and they're going to go over to you and do another 5 sets of 5 squats. Like that doesn't make sense. Or like they're with you and they just did a bunch of planks and then I come in and I'm in my circuit, I have planks. Like I'm not going to make you do 10 sets of 30-second planks. So I think that's one of my frustrations sometimes is like, okay, well, what are you doing? What am I doing? Let's complement each other. There's no purpose in double dipping. So I think having a strength coach that has a plan, like let's talk through it. I want to stick with your plan, maybe modifications where necessary. And that way you can do what you need. I'll hit other things to help prep you or to help, supplement what you're already doing. From a nutrition standpoint, I think pending the injury, certain supplements can be very beneficial. For example, like I mean, any post-op is going to need protein. Like education on yes, you're not lifting or exerting yourself or burning maybe as many calories of what you think, but your body is trying really hard to heal. So you actually do need more calories and you do need a lot of protein to help us build this muscle back. So that's a big conversation that a sports dietitian or registered dietitian will have with the athlete. The other big one is collagen, and collagen is one thing that's been proven to help with tendons. So not only like a chronic tendinopathy or tendonitis, but even your ACLs, right? Like they graft a patellar tendon, they graft from the quad tendon, they resuture it, so you theoretically now have like a new tendon that's trying to heal. So making sure that the athlete, if it's readily available to them, like they're getting collagen shots every day. Um, and then, sometimes I believe in it. They can't technically tell them to take it, but creatine obviously is a big one that kind of helps supplement with healing, especially with concussions. Um, and then we personally, we do in-body scans. I think that helps from like a muscle size or a body density kind of standpoint of, one leg versus the other. And then over 6 months, like, what does it look like? So, um, sports psych, we had one and then we've kind of changed our model a little bit. We had one at West Virginia. I think they're very beneficial. I think, you know, I feel it out with the athlete. Sometimes it's a touchy subject. I think it's becoming more common and readily available, but I think, it's something you got to feel out. You don't want to force it down their throat. Like, hey, you need to go meet with Bob over there because I think, like they would help you mentally. It's more of like, are you displaying patterns? Like, as we're progressing through this rehab, like, are you very fear avoidant? Are you scared to like load through your knee? Are you scared of what this sensation feels like in your knee now? Are you hesitant to go up for a header? Are you hesitant to go in for a tackle? Because that's how you tore your ACL. Like, understanding what their mechanism of injury was, as well as like, what are you displaying to me? What conversations are we having? And as I see that, as I recognize and is like, hey, like that might be something that I think sports psych can definitely like help you with. Let's process through it. It's normal. I would feel that way as well. Like maybe we should introduce to have that relationship with them. So I think that's something I just kind of feel out. I don't want to shove it down their throat, but definitely if it's something, if it's fear avoidance versus also just increased performance that we feel like they need at that end stage, then something that sports psych can help with. So I think right, there's a lot of different pieces, a lot of different components that can be utilized. I think the three main ones within our setting, from an everyday standpoint, is definitely AT, PT, and strength and conditioning. And obviously, you got your sport coaches. That's another conversation. But within the daily management of that rehab, I'd say those are the three key players. And then you have the accessories as well to help contribute.
Yeah, I mean, I think that's all awesome. I think it's I mean, you see that model like at the places that I know of that do a good job, like at least from the outside perspective, do a good job. Like that's definitely the model. And again, even at Fairmont, I feel like we have a pretty unique situation where we do have a counselor on campus that can do sports psych stuff, and it's something that, I don't know if we had this as a policy. It might be something for me to definitely ask, but it's almost like the minute an athlete gets injured, even before they go in for surgery, an injury that's like not like an acute ankle sprain, but like something that they're going to be out for miss the rest of their season, like they're going to go get an MRI. They're going to meet with the athletic trainer. They're going to meet with the surgeon. Like there almost should be like a process where like, I know you said don't force it down their throat, but at least we're like, hey, like you need to go meet with the sports psych and decide if that's something that you need to do almost as preemptively. Cause I think that's probably the hardest. What I've noticed with our athletes is like, that's when they really shut down, is like from injury point to like post-surgery. Like, or like, like once they've had the surgery, like that little phase in there, like when reality sets in of like, hey, like you're just going to miss your entire senior year now. Like, that's like probably the mentally the worst situation. Which again, I can completely understand why that would be the most frustrating and disappointing time. So I think that's something that I'm, as you're saying that, I'm thinking like, I don't know if we actually have like a plan in place, and maybe we do, maybe the trainers do, and I'm not aware of it right now, but yeah, I agree with you. And I think it's literally just letting everybody, the athlete only has so many buckets can be filled, but let everybody that's kind of their expertise fill those buckets in the best way possible, but make sure everybody's on the same page. I think that's obviously, again, the ideal way to do it. So you mentioned to me, like when we were talking before about like, and you said this earlier too, like your testing battery, kind of like how you maybe go about it with like an offensive lineman versus a wide receiver. Like what is, and I think I was texting you because we just got the force plates, and I'm trying to narrow down some of the things I'm looking at and just being as efficient and as effective with it as possible. What are currently, or what have you done in the past that you enjoy doing that maybe you don't, maybe at USC you guys are on the exact same sports science or modalities or whatever it is. What does that look like? What does that regular assessment of like, hey, here's the baseline stuff we want to have on all incoming athletes so that if they do get hurt, we know where baseline is. And then what does maybe that look like in terms of that return to play testing battery?
Yeah. So from a, preseason assessment, basically, we're actually kind of doing some of those right now in the weight room. We're lucky here. We have Vald. That's what we use. Other places though, like Hawkins and their force plates. We also had some Vald at West Virginia. So obviously it's really nice to have all the tech. So we've got the force plates, we've got the Nord board, we got the force frame. So we'll do just this past week within the weight room, they'll do like Nordics. So today they actually did Nordics, and we'll get a baseline of what their hamstring strength is side to side, and then per body weight, we'll do a force frame. So we do it in a seated position. You get hip AB adduction, and then a ratio of what that should look like, and then per body weight. And then we do counter movement jumps. So they do hands on hip counter movements on the force decks. So that's kind of a preseason screening right now of what we kind of utilize within the weight room, and then the athletic training room. I think that's also kind of evolving. There's been some other tech that's been presented us that we're kind of working through to see if we feel like we can incorporate that or not, and the logistics of getting, again, like over 100 guys through it, because it's got to be efficient, and then you also want it to be useful or beneficial. But right now, those are the three main things that we look at from a post-op return to play standpoint. Again, it depends on the surgery. So I feel like it's just easy to talk about a knee. We can maybe talk about a shoulder, but if it's an ACL, you got an O lineman versus a basketball player, a wide receiver. In general, from start to finish, I test them in phases. So around the like 12 to 11 to 12 week mark is where I'm probably going to get most of my beginning like big measures. Obviously, measuring range of motion along the way. I have a device, a biofeedback device called an M trigger that gives me like a quad voluntary contraction measure. So if you tell you like squeeze your quad, it gives me a number to what that squeeze was. So I use that in training along the way. So I'm measuring that all the way up until that 12-week mark. And at that point, then I'm starting to get strength measures. So I'll get a hip on the force frame. I'll do an isometric on, we have like a handheld dynamometer, or we also have a biodex that will do an isometric on them for peak extension and peak flexion. So I kind of have an idea of what is their quad and hamstring, because that prepares me to run. And then pending that, if the strength is good, it can deem them appropriate to start kind of pre-running activities, and then to get on we have an Alter G, so they'll start on the Alter G and then progress through that. And then typically around the 4 to 5 month mark, then we start incorporating more of like, jumps on the force plate. Can we do just a double leg counter movement jump? I'll do like a single leg squat test. We have like the Y balance kit. It's got 3 different directions. I only do the anterior one, so it gets like an eccentric quad. There's a lot of research on that test as well, like differences side to side. So I'll look at those, and then, again, as you get further out, you're doing more complex movements, then I'm going to test more things. So, again, a 300-pound O lineman, like, I'm going to do a double leg counter movement jump, but them compared to a basketball player, like, I'm probably not going to do a single leg counter movement jump. Like, it's not really worth, me trying to do that. Maybe long term if I really need to, but right now, like, I got a 340-pound dude right now, multi-leg, and I have no desire to really get a max effort single leg counter movement jump. But I do want to see double leg and see what that looks like. Versus a basketball player, like, you're jumping all day long. I need to see what your single leg counter movement is. And then I'll do horizontal stuff. So, there's traditionally like 5 or 6 different horizontal hopping tests. I personally feel like I only have time to do 2 of them. Like, they're all going to tell you similar things. So I do a single leg hop for distance, and then there's one that's a triple crossover hop. There's also a triple, and then there's like a timed, but again, like, it's all going to give you the same information. Obviously objectively what the number is, but then I use your coaching eye. Like, does it look terrible? Are they all hunched over? Is their knee caving in? So to me, that just gives me a little bit more of like an eye test of what you look like, because you can compensate obviously in a lot of different ways doing those. And then when we get to like more end stage, so I'm considering buckets, right? Like, what is your max strength of your hip, of your knee? Sometimes I'll even get down to the ankle. Like, what is your calf? What is your dorsiflexion strength? And then we develop into more like plyometric or more jumps of vertical, horizontal. And then we'll get a little bit deeper into maybe sport specific things. So I do like a 1.8, 145 cut where they sprint 10 yards, and I'm there with like my camera, and I'll do like a slow-mo. They'll cut towards me at 145 and then finish through a cone. And that's just, again, a more of a subjective way to analyze their change of direction. Like, what is you want to get deep in like the penultimate step, like, where's their foot position? Where's their trunk position? Are they lifting their contralateral leg when they're trying to cut because they can't eccentrically load it? What does that look like? Because if I can do it in a very controlled space and I'm seeing it look pretty terrible, what's going to happen when they got 15 coaches looking around them and they're all around their teammates and they got in the stadium? Like, it's going to look worse. So breaking down movement patterns as best I can in a controlled space to work on some of those qualities, to then take them out to the field in a more chaotic environment. Again, there's more stuff that I'm looking into. If you have a 1080, I have that at the other clinic I used to work at. We're hopefully getting one soon, but there's some research being done on like decel, of having a 1080 strap on you, having catapult, and like you basically sprint forward, come to a complete stop, and backpedal, and you can calculate all the stuff with it. I haven't got quite that far. I would like to, because I think from a running back or like a wide receiver, these soccer players, like high cutting, pivoting sports, I think really understanding like what is that quad doing in a max effort eccentric position. And there's really no way to like test it. Even the biodex, like, you can test it concentrically. And we have one device that I train on that loads the quad eccentrically, called the Kineo, Kineo. But it's like, nothing's published, like nothing is, you're sitting on a machine. So nothing you can really get from a true dynamic standpoint. That, in my opinion, I think is the one last thing that's really lacking, that we haven't fully measured or put a number on, outside of the cognitive piece, that's a different bucket. But
Right.
um, that's kind of my big battery. And then
Yeah.
again, if it's per person, I'll value different things, or hone in on stuff more. But
Yeah, I think it's great. I think it's like it's just kind of very like holistic. And one thing that I'll agree with you on, or like start off with agreeing on, is you mentioned the like the biodex, and then the what was the other thing? What was it called? Kineo?
the Kineo, yeah.
Yeah, like that. The thing with that is like with the eccentric strength is like I wonder sometimes too is like is open chain eccentric strength. Like if you did that and it like you had to slow the I assume it's like almost like an eccentric machine, right? And you have to slow
Mhm.
that down. How much different is that versus like actually doing that on the field with like
For
cleats on
sure,
and like controlling your actual
for sure,
body mass and the
for
forces
sure.
that are being applied from gravity and like the ground reaction forces. Like I think that's one of the things where sometimes I'm like, I think that stuff's great. Like the biodex is great and it tells you like the asymmetries and the strength, but how much is that? That's where like I think like a CMJ is not necessarily better, but it's closer to an athletic movement, I guess, would be the way I would look at it. When you guys are looking at CMJs, and I'm sure the strength coaches in the sports, do you guys have a sports scientist, or is one of the strength coaches kind of do that?
Uh, we did, and then they left in January, and we haven't filled that position. So more of the strength staff is taking that on right now.
Um, is there like I'm sure the metrics that they look at on the CMJ is different. For there's some overlap than what maybe you're looking at, but what are you? Is there because I know there's always the argument of asymmetries, but I think there has to be some truth to the asymmetries. I think like eccentric braking force or
Yeah,
braking power, like kind of going back to what you were saying about that quad strength and all that. Like, what are some metrics that maybe you're looking at
yeah.
from the CMJs? And I'm sure again it's always evolving, but what are you looking at in terms of return to play metrics?
Yeah, so again, it can get very daunting and overwhelming. And by all means, I'm not the sports scientist. I think I've leaned on a lot of kind of other mentors and colleagues for some of this information. But I pretty much narrowed it down to a counter movement jump. I'll look at content. So I look at the three different phases of the jump. If I can capture one piece within each phase, like let that tell my story to then let that compare to all the other batteries of tests that I've done and see correlations between it. But the three I like to look at are concentric impulse, eccentric braking impulse, and then peak landing force. So concentric, like the eccentric portion, concentric, and then when you land, what is that force? And then from a single leg, I'm just curious, honestly, the jump height, side to side, like your true power, like your height. What does that look like? And then same thing, concentric impulse and eccentric. So different phases of the jump.
Are you guys doing anything with asymmetries? Because like I'll give you an example. Like I know I was having this conversation with a guy that used to work for me, and he's helping at a D1 level now, and he was like saying how he doesn't really care about asymmetries all that much because there is functional asymmetries, 100%.
For
Like I'll
sure.
definitely buy that. But one thing that I've noticed is we have a kid that, and like I said, we've had the plates for 2 weeks, so we have two kids on the football team that have been here this summer that we've been testing, and one of them is he's like he tore it in the spring, so he's probably like I don't even know, 16 to 18 months post surgery. I don't know. I'm guessing. It's longer than a year. It's been longer than a year. I can't remember exactly.
Yeah.
And then we have another kid that has like a foot sprain or a small chip on a bone in his foot.
Right.
And they both are favoring their other leg by like 20+%. Like I think that's statistically relevant. Like again, without knowing their
Sure.
without having baseline numbers on them, just knowing where they're at. And with football season 3 weeks, well, 4 weeks away from the season, 1 week, like less than a week away from, exactly a week away from fall camp starting.
Yeah. Yeah.
I think that's something that we would want to be aware of. And then, just let's say we have a kid that's 50-50 or 100%, not favoring each leg 50-50. And then as the season goes on, it starts to go 10 to 15, 10, 15, 10% difference, 15% difference, 20% difference. Even though he might
Right.
not be injured, is that showing us something where there is something coming down the line as a potential
Right.
injury risk? I think it's worth at least looking at. Is that something that you guys
Yeah.
pay attention to asymmetry at all?
Yeah. Oh, for sure. Definitely do. I think, I'm biased of like injured versus a non-injured kid. Like clearly you're going to have asymmetries that I care about because, you've lost your quads atrophied, you've lost muscle mass, you've lost power production. And when you're doing a jump and you're shifting on, you're very avoidant. Well, then if I throw you back out, like I'm putting you at a very high risk of not loading that leg to honestly injure the contralateral side.
Yeah, exactly.
So I definitely, from an injury standpoint, and the traditional like, less than 10%, I found when I test these guys like personally once a month, like you probably should be testing more. And I think that's what a lot of sports scientists will tell you, like try to test weekly, because just doing that one test, like, and you cue them, hey, I need you to like load more forward, or hey, like you're really shifty, fix it. And all of a sudden the second jump is like, instead of 50%, it's like 20. It's like, okay, well, if I just cue you. So I think it's more so tracking trends over time and not solely looking at one jump and saying, whoa, you got 30%. You look
Yeah.
terrible. We need to work on stuff. Like, okay, what if you test him tomorrow when he got 5 hours of sleep instead of 3, or he actually ate before he come in, or his girlfriend didn't break up with him? Like, how are you monitoring it over time versus just that one sole moment? And I think I'm
Yeah.
learning that too, of when I do my battery of tests, um, like, and then I put them on the force plates that one time. Well, that compared to the last time, I may not see too many trends, because I did it every other day or twice a week. I'm able to see more trends than just that one jump. So I think that's one thing that I'm learning. I need to probably change it in my program of just seeing trends in my ACLs. Um, that what you don't want to base or assume things off of just one day.
Yeah.
Um, Specifically with
I
the jump.
Yeah, no, I think that makes sense for sure, because yeah, things could be day to day, and that's something that so we used to use the jump mats, and now we have the plates. Like, we're gonna kind of can still continue our same testing battery. So for out of season teams, we basically alternate vertical jump, broad jump, vertical jump, broad jump. So now it'll be like vertical jump, CMJ on the plates, broad jump, but for in season teams, we were testing CMJs essentially every week. Whatever that first lift was of their
Right.
week, that's when we're getting them in there. And we're going to continue to do that. And that's definitely something that, like, if a kid's at like 3% favoring the right leg, and then the next week they're at like 11, probably not a big deal. The next week, now they're at 14. Okay, now maybe we need to start thinking about it. Like, it's like, okay, let's see. And the thing is, we're not really going to have a lot of, like, we have 10 to 12 guys that we're going to have baseline data on that we're here in the summer, right? So aside from that, everybody else is going to be starting from scratch. So that's the thing. For me, it may not be something that we catch anybody. We don't like prevent any injuries this year, but by next year, now at least if we do have somebody get injured, now we know, hey, before you got
Right.
injured, you were 3% favoring your right leg. Now you're
Right.
33%. So like now
Right.
we can try to get them back to their original baseline.
For sure.
Um,
For sure.
last thing real quick on like injuries and things like that. Obviously something that we really haven't had a lot of. We had a handful this spring with football with hamstrings, but we really haven't had a lot of hamstrings over
Yeah.
the course of kind of your career. Like I'm a big believer, and I'll just put it out there. I think you probably know this. I'm a big believer in sprinting is the anecdote, right?
For sure.
To hamstring strain preventions, but workload has to be factored in, fatigue has to be factored in, nutrition, all those things have to be factored in as well.
Yeah.
So even if you're sprinting once a week, but the kid's not sleeping or not eating, then it
Right.
could be pointless. But what have you kind of seen at the places you've been? Like, what is your thoughts on, and this is not return to play. This is more so just driving up performance / reducing
Yeah.
injury risk. And then if you want to answer that with kind of like at one point, when do you start implementing sprinting back into a potential hamstring strain
Right.
injury?
Yeah. No, for sure. I think just to start, it's hamstrings are always a topic of conversation, right? Because when you get into preseason, that's typically when you see a lot, or when you first start up that spring season training program, you'll sometimes see a lot of the hamstrings. And unfortunately, they happen. Now, obviously, we can help reduce like the risk or help reduce the number that you have based off of training programs implemented. But at the end of the day, you're always going to have some hamstrings. And like you said, it could be sleep, it could be stress levels, it could be volume of stuff they're doing, not taking care of their bodies. But I think from a true like training standpoint, um, sprinting is rehab, and rehab is sprinting, right? Like you have to introduce that stimulus at a microdose level or kind of methodically to build the resilience and build the capacity within the hamstring. So when it's game day and you're asking them to go sprint 21 to go, catch the ball, like that's not the first time that they've ever done it. So yeah, I'm a firm believer. I'll say from a rehab standpoint, like if you tore your hamstring, you're grade 1. My criteria to get you back into sprinting is basically like, do you have within like 85 to 90% of your true like range of motion or more, neural tension, pain, tenderness, um, and then like overall just global like resistive strength. Like, do you meet those? can you do some dynamic patterning? And then let's get you jogging. Okay, now let's get you jogging a little faster. Okay, now let's have you do some sprint mechanic drills, skipping, bounding, dribbles, like whatever that looks like. Use those little drills as a micro dosing to then, okay, now let's go 10 yards. Okay, let's do multiple reps of 10 yards. Tomorrow, okay, now we're gonna open up to like 15 yards. Let's do a certain amount of volume. How does it feel? Feels a little tight. Okay, let's back off. All right, next day, let's build up to like 15 to 20. And you're just slowly progressing, the distance with the volume to build the capacity to ultimately, like, I need you to open up. So that was kind of actually one of our guys. He's 2 different knee surgeries, was out basically for 2 years, came in. We had to work on a lot of stuff. He's back from a knee standpoint. Now we're battling a lot of soft tissue. And he had a hamstring actually while I was at my wedding. And then I come back, I'm like, oh gosh, we got a hamstring we're dealing with. He got back within 2 weeks and then kind of retweaked it in a different area. So now, okay, let's go back. Well, obviously we know you've been out for 2 years. You're going to have a lot of volume management issues. So we need to figure out, like, what is your volume that we need to have you hit so you don't keep having recurring hamstrings, but also like you're wearing catapult, like what speeds are you hitting? What percentage of those speeds do we need to hit building into the week? And then I told him last week, I was like, have you hit like a true top speed yet? And he's like, no. Like, well, we need to freaking hit one before you get to camp, because if you don't, you're in a recipe for disaster. So, I think that's just conversations with the athlete. Like, how do you feel? What speed do you feel like you're hitting? Conversations with whoever's running the catapult, whether that's the sports science or that's strength and conditioning. For us, it's our strength coach, and then one of our athletic trainers kind of monitors the speeds. And then communicating with that sports position coach of, like, if you're a wide receiver, like, hey, this kid, like, if he can't make, the reps in this type of drill, I need to pull him aside and he needs to hit 1 rep so I can see that he's hitting, 80%, 90% of what he needs to hit. But a lot of it is subjective feel. Like, you can't say, like, I need you to go run like 90%. Well, what if his 75 feels terrible, or it feels like it's pulling, or he's about to pull it? Like, maybe you don't need to hit 90 that day. So a lot of that's, I think, communication with the athlete. That's more from you've done it once, or rehabbing you. Obviously, you can't speak with each individual kid and say, hey, how's your hamstring? Don't run that fast. But in general, I think it's the volume management. It's the you got to hit it at some point, and we got to build you up to that. I think that's the purpose of spring programs. Like, build strength, build resilience, build distances and volume of that sprinting capacity. So when you get to camp, you don't pull it. But unfortunately, I think sometimes it's the reverse of it's too much volume, and they go off and train on their own as well. And then they come back and they're wondering why they have all these soft tissue injuries too. So we battle that as well.
Yeah, no, it's definitely, like I said, I think we've actually been pretty fortunate at Fairmont, talking to like some of the other coaches I know, like at the D1 and at the D2 level, like, and injuries always seem the worst in the moment. Like, it always seems like you have like 3 or 4 at the same time, and then like a month will go by. Like, you know what I'm saying? It's like, and so it always seems like it's at the worst in the moment. And we really haven't had a lot of soft tissue injuries during football season. Really any other sport hasn't had a lot. But like, for whatever reason, this spring we had a handful with football, and we had like 2 or 3 baseball guys too, which again, we very rarely had some. And one of the baseball guys was like, he literally has had one like all 4 years of his career. Like, it was just something that just, once the season starts going, he just wears out. And to be honest, we kind of stopped sprinting them as much in season, which again, I'm like, I don't know if that's what we should be doing. I think we maybe should be sprinting them. This is kind of like a out of left field kind of question, because it's something that I think about, actually kind of 2 topics that I have looked into recently, and then we'll get into some of the rapid fire things. Fascia. So, and the reason I even thought about this, because I had it in my notes, but we do RPR. I'm sure you're familiar with RPR. I don't know if you believe in it, which we can say that for episode 2 at some point. But RPR, I think it makes some sense logically. It seems like it works. I think it's maybe a factor of maybe why we've had so few soft tissue injuries. And obviously it's some sort of fascial neurological reset, whatever you want to call it. And I know there's another one coming out too. Oh, it's not RPR. It's oh my gosh, what is it called? People use it with RPR. I cannot think of what it's called now. I'm blanking on literally what it is. But anyway, the role of fascia, like, well, so I'll just start with that. Like, what do you like? Is that something that they're even teaching in PT school? Like, cause like when I was in school, I don't know, undergrad, I don't know if I ever learned the word
Yeah.
fascia other than like it was on a picture of a diagram one time. Like, is
Yeah.
it real? Should we be worrying about it?
Yeah. So is it covered in PT school? No. Like we learn what fascia is from an anatomy standpoint, like your lumbar fascia, like all the muscles come into one kind of like tendon fascia connective tissue. It's every muscle is layered in fascia. Like we learn from an anatomy standpoint, but how it's all interconnected and how it contributes to muscle function, no. I am familiar with RPR. Like we kind of had it a little bit at Liberty. I think one of the strength coaches was trialing it for the first time. We did the behind the ear, we did the sternal rubs, we did a couple positions. But then, I didn't touch it for 3 years or so. I remember going to Pro Performance, and I remember you guys talking about it a little bit. And it's funny because literally last week we partner with a research lab that does motion capture for us. And I was just speaking with him of like, we found these deficits. I was like, what do you recommend? He's like, I think doing RPR in this way could help wake up this muscle to then better execute this task. And, someone was like, wow, I haven't heard of RPR in a minute. Like I can't say I'm a believer in it. I don't disagree. I can't say I'm all for it. I think it's something I'm not educated enough in. I remember using it. He sent me a couple articles. It's actually on my list of things to kind of reread and touch up on. Because I do remember there being benefits and seeing guys like, the change that it felt for them. Sometimes I do feel like it's maybe case by case basis, their neurological system, if they feel like that helped, prepare them for that task. But I don't know. I feel like I can't spend 10 minutes talking about it because I'm not as well versed. I do feel like, fascia it's a whole body connection, and I've heard some PTs that are really big into it, and they find ways to have it connect into, your ankle hurts, but it's because your shoulder and this and that. And I think it's interesting. It's something that I would love to learn more into and dive more into. It's just something that I personally haven't yet.
Yeah.
Um,
Well, I know like one of the guys that, and I'm mad that I'm blanking on the other. It's like an assessment, like an evaluation thing that you do. I don't know if you're familiar with Dan Fichter, and I can send you some of the stuff, but he's actually a high school football / high school strength coach up in New York or New Jersey, somewhere up there.
okay.
But
Yeah.
he's kind of in that same like Chris Corfist, um, Tony Holler, Cal Dietz, kind of in that whole
Yeah. Yeah.
network of like that
Mhm.
group of guys. And he does like this neurological reset stuff. You've probably seen people do like the
Yeah.
infinity runs. Like he does like
Yep.
that kind of stuff where he looks at like how the visual cortex, like how all that's factored into your speed. Like if you can
Right.
sprint, like look over your right shoulder, but you can't go fast, but you can look over like that means that you have some sort of like neurological. So like
Mhm.
it's stuff that like it seems a little voodoo, but I think there's also
Yeah.
like there has to be some truth to it because again, I think everything is, in my personal opinion, everything's connected. Like I
Yeah.
think
Yeah.
it makes sense that like you fix a hamstring strain, well, then this person has a rotator cuff on the other side. And then you fix the rotator cuff, and now he has a calf strain on the other side. You get like, I feel like there's an underlying issue, a neurological, fascial, whatever you want to call it, that it just keeps bouncing around. Like that's
Yeah.
my thing is like sometimes it's like
Yeah.
you stop one leak here, but then another leak starts. Like it's kind of that mentality. I just think that to me just makes sense. I think that's the body
Yeah.
just is a big system
No,
and it makes sense.
for
Um,
sure. I don't
what
disagree with it.
about like for I know the big thing is like we talked about eccentrics a little bit already, but like obviously like the Jake Turra, like jumper's knee protocol and all that, like the eccentrics, the isometrics. Do you feel like that's something that's as valuable as what it seems? Is it still undervalued? Is it underutilized? Like where does all that kind of fit into like rehab, but also training? Like is doing like the Dan Fichter talked about like the Jay Schroeder, and I don't, you may not know who that is, but like the 2 minute, the 5 minute isometric split squat holds.
Yeah.
Like is that something that you're seeing more of that kind of
Yeah.
grow and believing into it
Yeah.
or what?
I personally, that's something I've kind of evolved a lot in my dosage of isometrics. In residency, it was taught a lot of certain papers like a tendinopathy or an Achilles tendinopathy of what is the appropriate dosage of isometrics. And, when you go ask a lot of PTs, they're like, you're obviously 3 sets of 10. But they'll do like, 5 second isometrics or 10-second isometrics. I'm like, you're not loading that. Like, that's not enough. So there's one paper, and I'm blanking on a name too off the top of my head, but she's really big in Achilles rehab and talks about your total loading dosage to be around 240 seconds. whether that's from a, open chain position or closed chain position, but hitting that like 2 to 3 times a day, pending the irritability of the tendon. Um, but yeah, I would say there's a lot of underdosing going on with isometrics, and something that I've personally fallen into some of, okay, let's go 30-second holds, 3, 4 rounds, let's go do a split squat. But like all in all, I might only be doing, 150 or 180 seconds of total loading. So I've definitely got into a lot more recently of like 45-second holds, a minute holds. But not only just holding is then throwing on that M trigger, the biofeedback. So not only are you just trying to kick and hold, but you have an output or a threshold that I need you to hit and meet the entire time. So you're not kicking while you're playing on your phone and going through TikTok. So I've been utilizing that a lot more. But yeah, I would say in general, a lot of isometrics are underdosed for sure. And making sure that you are truly loading the tendon to be able to change the properties and the irritability of it. And then obviously filtering in the eccentrics and getting into the slow time under tension, like not just up and down, but like 8 seconds, 10 seconds down, do your pause, help yourself back up, slow 8, 10 seconds down, and then add weight with it. So, but I'm learning too, like it's an art. It really is, of tendons. And I've got a quad tendon graft right now who's a year out, and just, it's painful for him and painful for me to just figure out what is the dosage, how can I let you go do lift and go do sprints and runs, but then also load you and make sure you're appropriate from it, but we actually need to modify you, and we got camp in a week. It's a battle. Tendons, when they get really chronic and irritable, are a pain to deal with.
Yeah.
So
Yeah, no, it's definitely something that like we've leaned into a lot more with just putting it into the program in general. But then obviously if kids start having like cranky knees or whatever it is, like
right.
doing that. And it's kind of funny. I always think back of like I remember being in like middle school or high school and like just doing like wall sits like in gym class. And like
Yeah.
it's like wall sits disappeared for like 20 years, and now isometrics are like
Yeah.
the thing that's back in the game. But all right, rapid fire. When I say rapid fire, your answer doesn't have to be short. I just need to not talk. I need to just give you the question. All right. All right.
Okay.
So what is a training rehab hill that you're willing to die on?
I think it's honestly what I literally just talked about that came in perfectly, is that PT as a profession, we underdose significantly. I think a hill I'm going to die on is like, you don't be afraid to load. You need to load, you need to monitor, you need to adjust, and then you need to load again. And I think as a profession, we underload, or sometimes it's even on the flip side of like, I'm a sports PT, I'm just going to jump all of a sudden into this excessive amount. And our dosage and our load just aren't progressive in nature, I think is a big problem.
Too far on usually one end of the spectrum, but maybe sometimes the other end.
Yeah.
All right. This is a weird one. I've never asked this question before, and I think it's cool. Do you have a favorite injury to rehab?
Personal bias, definitely the knee. I think I feel like I relate with them. I feel like I throw my own personal, like, I feel like I have 40-year-old knees right now, unfortunately. So I feel like I relate with them. I understand to a sense what they're going through. When they do a movement, how I remember it felt for me. So I think I have a passion. I'm here doing what I do because of my knees. So I think I naturally relate with them on a
Yeah,
deeper level.
that makes sense. All right. Person that you'd want to have dinner with, and they can be dead or alive. You can already know them. You could have like whatever it is. Person that you most like want to have dinner with.
So gosh, probably I'm just gonna be super like short, sweet, to the point, really cheesy, but definitely my husband. It's we work long hours, and we just got married 8 weeks ago, and I think when I come home now, like that's what I look forward to the most right now. Like, let me just sit. We don't even need to talk to each other. Let's just sit, eat
Yeah.
some burgers, and just enjoy each other's company. So I think
Yeah.
sometimes in silence we enjoy.
All right. I'm gonna have a follow up to that question, so just hold on for a second. All right. So what's a book that you've like, and this can be any book, doesn't have to be a strength and conditioning, sports performance, PT book. What's a book that you've read like more than once that you just really like to read, or that you just recommend others read?
So I'm the worst. I'm honestly a person that, like, I've barely read through a full book. I'm the person that will get through a portion of it and think about another book that I'm really interested, and I'll skip through the table of contents and read sections that I probably want. So I'm the worst from that. I would say it's funny, it's not even really PT related, but when I was in PT school, I read Why We Sleep by
Oh yeah,
shoot,
Matthew Walker. Matthew
Yes, Matthew
Walker. Yep.
Barrett. Oh my gosh, I literally took notes on every, like I have a book report on that.
Yeah.
It blew my mind. So I would say that one that has changed a lot of how I think and feel about sleep in and of itself. But then I'll say, like, to be honest with you, the past year has been more personal life and wedding planning. And I didn't really talk about it. Like, we're starting a sport residency program here and trying to get accredited with that. So when I come home, if I'm going to read something, it's honestly a bit more personal life of just what me and my husband here, like what we're doing and like our spiritual growth. So we've been reading a book called Cherish. And just not only how to love and cherish one another, but just people in of itself, people that I
Yeah.
work with every day in the training room, on the field. Like, how can I connect with them and love them in a different way that we're both called to do. So
Yeah.
sometimes I get burnt out of PT things. So
No, I definitely get that. And it's
right now
actually, since we've had Ruby, like I probably read, and not just Ruby. I mean, I want to be a good husband too, and a good father, but also just like try to be a good person, be a good coach, be
yeah,
a good coworker. And so I've actually read, like, I used to read pretty much 90% strength and conditioning stuff, or I listen to mostly audiobooks, but I do read, like, strength and conditioning books, strength and conditioning audiobooks. But then I went through a phase where I was reading, like, listening to a bunch of like history books, like stuff about pirates and about Native Americans and
mm,
about
yeah,
Vikings. And then now,
yeah,
like the last like 2 years, like it's like every other book I read is something about either like personal development or like
yeah,
being a parent like
for
that.
sure.
Those books are really cool. And I actually texted my wife the other day because the one I was reading, man, it like almost had me in tears on the drive down the road, because it was like just talking about like what a signs of like a well-rounded kid.
Yeah,
And Ruby's only 2, and I was like, I texted my wife when I got to work, and I was like, man, I don't know what we're doing, but we're doing something right. Like, we're just doing
yeah,
something right, because she's freaking awesome. So,
yeah.
um, uh, all right, what about anybody that you would recommend as like a podcast guest? And maybe they wouldn't even ever do it, but somebody that you would recommend that or somebody that you would be like, Adam, you should try to get this person on. Like, I've never talked to him, I don't know him, but you should try to get him on.
Yeah, I mean, I would say I'm biased towards a medical lens. I definitely have several colleagues and mentors that have poured into me that know a lot more than I do. But I have a couple people like in performance, from a college setting into the NBA. So I mean, if it's something that you want me to reach out to them, one's in college baseball at Duke, and the other one's was in college football and now is in NBA in Atlanta. So a couple people there, I'd be happy to reach out. I think those are two mentors I've had, and then some are in private practice. They actually just called last week about this tendon thing, and she's like, "Hey, you need to read about Keith Barr." I had no idea who Keith Barr was, but
Yep.
listening to his podcast now on tendon loading.
Yep.
So again, a lot of people have poured into me that are a lot smarter than me, from a PT medical side. That more than
Yeah.
happy to connect you with them.
Yeah. I'll definitely try to like have you text me those people and get in touch
Yeah.
with them. All right. Two fun ones. If you had an NIL deal, so you as Amanda Hundley, the physical therapist, what would your NIL deal be like? Who would you want to partner up with?
It's funny. I know you helped me. I tried to prep on some of these questions, and this one stumped me. I was like, I don't know. Doug was like, you know what you need? You need an avocados from Kroger NIU deal. I am a huge fan. Like, I would eat an avocado a day if I could actually get them to be ripe enough every day.
Yeah.
I make the best guac. So he was like, you should do avocados from Kroger because then you get free avocados. I'm like, that's a great idea.
Yeah, there you go. No, that's good. Yeah, that's the problem with avocados, is like you buy them and like they're hard as a rock, and then 3 days
Yep.
later they're all freaking mushy.
Yep.
So,
Fridge. You got
um,
to put them in the fridge. The fridge helps. I found
okay,
that.
yeah. All right, this one was not.
Yeah, my phone died.
That's okay. All right, so that's fine. This
Wrap
last
it up.
question. Yeah, this last question. All right. Um, and this is funny. I did not give you that. Didn't give you these on the notes. All right, everybody wants to know, or at least I want to know. I think everybody that knows Duncan wants to know, what's it like being married to the Duncan Hundley?
Oh my goodness. It's an adventure. It's something new every day.
Yeah.
From a like, I mean, we got married, we bought a home, we got back from a honeymoon 2 days later, and we got a dog. So we literally have done everything all at once. And I think it's learning each other, but now learning how to take care of a poodle, and the
Yep.
energy and the feeding and picking up its crap out in the backyard. So it's an adventure every day. He's a ball of energy, as you know.
Yep.
But I think the piece that I get, and I can't say this too loud because he's downstairs, but you guys see the always on, the high energy, the raspy voice yelling, but he's like a teddy bear when he gets home. And it's
Yeah.
just
No,
sitting and he's very, very, low key, and that's the side that I like about him.
Yeah, no, I could definitely see that in him. You can tell there's like that teddy bear energy deep down inside there somewhere.
For sure.
And the dog thing, like that's like practice for a kid.
Oh, it is. It is.
Like a
For
dog
sure.
is a dog. Honestly, sometimes a dog might be harder than a kid, anyways. So,
The only
but
difference
no,
is you can leave the dog at home for 5, 6 hours. I don't think you can leave the kid technically alone for that long,
yeah,
but
yeah,
we'll learn that piece.
yeah, it's frowned on. It's frowned upon to do that with your kid. Well, tell Duncan I said hi, and I really appreciate you getting on here. And we talked long enough that your phone died, so I
Yeah,
appreciate you being on
no,
here.
this is great.
I think it was an awesome episode, and I can't wait
Yeah,
to kind of get it out there and share the information.
yeah. No, thanks again. I really appreciate it, Adam. Look forward to it. More
All right, man.
conversations.
Yep, keep doing great things. Appreciate you.
Yep. Thanks. Yep.
Yep, bye.